Hi, everyone. We're going to get started in about 2 minutes. We're just going to give everyone time. The numbers are growing here with people entering the room right now. So we'll just hang tight and we'll get started in about 1 or 2 minutes. Thanks. All right, looks like the numbers are leveling out a bit here, so we'll get started. I just wanted to say thank you to everyone for coming. This is one of our virtual career exploration programs. This one particularly is Respiratory Care, and it's hosted by Wellspan York Hospital. And the team there for many years has done such a great job just bringing awareness to this program and allowing students to explore this very specialized field. It's honestly, no pressure here, but it's one of my favorite programs that we get to go to. It's usually highly interactive. Unfortunately, because of various restrictions, obviously we can't be there in person, but they've done their best to improvise today, and really appreciate that. 2 things I just want to mention. This information, I just saw this come out. I was just made aware of this earlier today. This number here, if you can see at the very top, it says -476, and that is healthcare practitioners. What that data means is, in theory, if we were to find 476 new healthcare practitioners in South Central PA, they could all get jobs. That's the theory on how short we are in the labor force with healthcare practitioners. So it was very, I don't know how into numbers you are, but just the idea is that if you go into this field, there's very good job opportunities. I just wanted to mention that. Before we start, I actually have a poll here. I wanted to show everyone or ask everyone, if you don't mind interacting here, really just seeing how familiar are you with what it is to be a respiratory care therapist. So you can go ahead and select that. We'll give you about 30 seconds to a minute here. I'm very familiar, and I've met one before, because we see that very often, that maybe you or family members have some health situations where you've got to work with one specifically. I'm somewhat familiar. I don't really know what one does, and that's good, because you're in the right place. That's the whole point of today, is to explore and find out more information. So that's great. And thankfully, I'm not seeing anyone say, I think I'm in the wrong webinar. So that's good. We don't want that one. Okay, we have just about everyone has answered here. So I'm just going to go ahead and hit end, and I'll show you those results. So it's pretty good. We have one person who's very familiar, and they've met with one before. And then it's a split, 60%, 60% roughly. That doesn't add up. That's 120%. I'm somewhat familiar. I don't really know what one does. So that's good. This whole program is meant for career exploration. We want you to end this program today and have some more information so you can make better decisions for yourself and where your career is going to lead you. At the end of the day, you might need to still look for more information. That's fine. You might say, this is for me. I want to do this. That's awesome. Or you might say, you know what, this isn't, I don't think this is the direction I want to go. I need to try something else. That's okay too. The whole point of today is just you have more information at your disposal, and you can make a good sound decision based off of that. So anyway, that's enough for me. I took up way too much time. I'm going to kick it over to Tony and his team, and they're going to take it over from here. And I just want to say thank you all for coming. This will be made available. I know everyone's class schedules are a little different. We are recording this. It will be available on demand. So if for some reason you would have to leave after 40 minutes or 45-minute class period, you can use that same registration link. It'll be available about an hour and a half to 2 hours after, pretty much by 2 o'clock today, it'll be available. So you can just click on that same link, and it'll take you to the on-demand version. So, All right, I'm gonna cut out here, and Tony, take it over.
Well, thank you, Kevin. Hopefully everybody can see me and hear me, things like that. This is so strange not being able to see people as you talk. But again, thank you, Kevin, and thank you to everyone that is attending our little webinar today. So sorry that you can't be here in the hospital to attend and get your hands, you won't get them dirty, but certainly in years past, we have had many people here to experiment, to get their hands on things and to play with some of the equipment that you're going to see over the next hour or so. So Kevin's poll showed that one person is very familiar. And then the mix was maybe I know something, maybe not. How many people, and I know I can't really see you, but how many people have heard of COVID? I'm hoping out of everybody on there, everybody has heard of COVID, hence the reason why we're on this Zoom. Guess what? Respiratory therapists are extremely involved in the care of COVID patients, especially those that have lung disease. And when you hear about people needing ventilators, when you hear about people requiring life support, needing having trouble breathing, guess who helps them? That is the respiratory therapist. We are active from the first breath to the patient's last breath. And unfortunately, again, we see a lot of that. So I don't want to be dismal today. That's the job of some of our students. I'm thinking about one in particular. But anyway, we deal with babies, we deal with for the whole life spectrum. So respiratory therapists, what you're going to see is some of the equipment that we use today, and that's again how we usually keep you interactive. But we are going to walk you through today in our classroom. I'm in my office, so that's why I do not have my mask on, but I have it right here. But we're going to walk you through a patient coming into the hospital who has maybe some respiratory type symptoms, maybe a cough. We don't know what. So they're going to come in and they're probably going to get a little bit of oxygen, and then we're going to give them treatments that respiratory therapists might do. And you're going to see a whole progression from a patient that seems stable when they come in to a patient that seems to be becoming more and more unstable. And so you're going to see that, and you're going to see a respiratory therapist, how they participate in that care. So if I could see your hands, I would ask you, how many people know about doctors and nurses? Obviously, everybody knows about that. And unfortunately, sorry about that. Unfortunately, everybody hears about doctors and nurses. If you're thinking about being a doctor or nurse, that's absolutely great. That's wonderful. But I consider respiratory therapists one of the unsung heroes, especially in the COVID crisis. You don't hear about respiratory therapists right now in this field, in the crisis. You do occasionally, but again, respiratory therapists deal with everyone that's acutely ill, the people that need the biggest, the most critical patients have a respiratory therapist at the bedside. And so our job here today is hopefully get you excited, maybe let you know about respiratory therapy, get you ask more questions to understand that there are different careers out there other than doctors and nurses. There are many people. In fact, we work closely with nuclear medicine. We work with radiography, people to take chest films. We work with a lot of those people, and those people we're all very important to care of patients. So again, I'm glad that you're here today to explore. A few more last comments, and then I'll turn it over to our friends in the classroom. Respiratory therapists need at least an associate degree to get a license. So in 49 of 50 states, respiratory therapists require a license to practice. You cannot just be a respiratory therapist without a license. You need to pass a credentialing body exam that's national. So the students that you're going to see today who are just a little bit older than you, they will, in a couple years, they will be passing two or three exams so that they can practice anywhere in the United States. However, the students that you're going to see today will all graduate with bachelor degrees. Again, however, the minimum to get into our field is an associate degree. If you are considering any healthcare degrees at all, I would absolutely recommend that you consider pursuing a bachelor degree right away. It's only a matter of time before nursing, before respiratory, before many disciplines mandate a bachelor degree to even enter the field. And in fact, many of our respiratory therapists across the country have a master's or a doctorate degree. All right, I will stop there. I'm going to turn it over to our classroom. Shannon is my partner over there, and she'll help direct things. And again, welcome. Please ask any questions, and we will take some questions as we go through, or we will wait until the very end, and I have another video for you, and then I'll answer more questions. Thank you all.
Hi, my name is Shannon. I am the Director of Education for the school. And Mitch here, he said he doesn't want to be involved, but hi, Mitch. Mitch is one of our clinical instructors. And as Tony said, we're kind of going through the progression of a patient that comes into the hospital, maybe short of breath, maybe with a cough, and you'll see all the things that we respiratory therapists do for them. So I'll let you ladies introduce yourself first.
Hi, I'm Jenna. I'm a junior respiratory care major. I'm Jules. I'm a junior respiratory therapy major. So when the patient first comes into the hospital and they're on their bed and they present with respiratory problems, we're gonna place a pulse ox on them, which tells us their pulse and the level of saturation of oxygen in their body. I did. Not yet. Okay, so Jules' saturation is 99%, and then her pulse would be 106.
I think that's a little off.
Calm down, Jules. Calm down.
What would you guys do if our saturations were, say, 80 or 70?
So when we find out that their saturation is lower than 90%, we usually will put them on a nasal cannula, which is low flow. Yeah. So we'll put it in their nose, this, and drape it over their ears. And then we'll go to the oxygen tank and turn on a certain flow level, which will help bring their saturation levels up.
How do you feel, Jules?
My nose is a little dry.
Awesome. Thank you, ladies. That's fantastic. So if someone needs a little help with their breathing, there's other things we can do. And these next two ladies will show you exactly the medications and the instruments that we use to do that.
Hi, I'm Tara. I'm a senior. I'm Sarah. I'm a senior. So if a patient requires medication, these are just a few of the medications that we have. They kind of help open up the lungs so you can get oxygen to the lungs better. So we have a few here. So they're all kind of like inhalers. As you can see, these. This is called a spacer. So we use these a lot because it helps give the medication like a lot better. So it can like hold it in the chamber and administer to it. So you kind of use it, you'd shake the medication first, you put it in here, patient puts it up to the mouth, you push it in, you wait like a minute, and then you do it again. This one right here is a dry powder. So you would open it like that, you give it to the patient, they inhale, hold it for 10 seconds, and go on. These are just a few others. So we actually have a asthma patient right here. So she's going to kind of demonstrate how you would take the medication. And with certain medications, such as steroids, you want to rinse your mouth out with water and then spit it out so you don't get a fungal infection in your mouth. So she's also going to demonstrate that.
Yeah, so this medication is called Brio. It has a steroid in it and a long-acting beta-2 agonist, which means basically it opens up my airway after a long period of time. So I take this every day to maintain my asthma. So this is how you do it. You click it open like that. Okay.
You want to hold for 10 seconds.
And then I have a cup of water that I rinse my mouth in so I don't get that bacterial infection. Spit back out, and you're all good.
Another thing that we do is you can do an aerosolized medication. So I'm going to demonstrate that too. So you give this to the patient, they put their mouth on this and they hold it in for as long as the medication is needed. So you would turn it up, and you can't, it's kind of hard to see, but it kind of blows it out into the patient's mouth until it all goes down. And that's just an aerosolized form of the medication. Other things that we do that help open up the patient's airways. This is called an incentive spirometry. When a patient might have decreased lung volumes, we instruct them to use this, and it helps open up their, helps force them to take a deep breath and open up their lungs. So I'm going to demonstrate that now. You want to try to get this like this little dot. It's going to move, and you want to try to keep it like in the middle here. Back. The mouthpiece isn't that good, but this is going to move up slowly, and it can kind of tell you the lung volumes that they get, and you want to instruct them to do it 10 times, like every hour. And it just forces them to take a deep breath and to open up their lungs. This, you're going to blow out into it, and it's going to kind of flutter, and you can hear it too, and it helps force pressure into the back of their throat to open up their airways and kind of force a cough. To loosen secretions when patients can't necessarily clear their secretions and cough on their own. So I'm going to demonstrate that too. So I don't know if you can hear that flutter, and then the patient can kind of feel that flutter like vibrate down into their airways. If a patient can't do that, or if they have a lot of thick secretions, then they would have our next station, which is the cough assist. And the cough vest. Yeah, the vest. Go ahead.
So for our patients who, like Tara said, can't necessarily do that on their own, whether they were in an accident or they have a condition where they can't do this on their own, or they need a more invasive or stronger approach to this, this is one of the machines we can use. So the patients, if you guys ever heard of conditions like cystic fibrosis or something like that, these patients routinely do this at home. So while it's going to get Brandon all set up here, this is something that just helps inflate, and then it shakes loose those secretions so they can get them out later.
So like Mitch said, that the vest helps get the retained secretions loosened up into bigger airways so you can cough them out. And so you attach the hoses at the ports in the machine and then on the vest. And this is one of the fancier vests that the patient would have at home. At the hospital, it's more like a singular thing that just wraps around your body. But then you turn it on and you select the hertz and how fast it will vibrate and how long. It's usually for about 10 minutes. And then as it goes, the frequency is, so it's at 20 now, so it's fast, but then when you go lower, it slows down. And the faster and harder that it is, the more successful it's going to be in getting the secretions out of the airways and being able to help you breathe. And CF patients do this 4 to 6 times a day for up to 30 minutes on top of everything else.
What does CF stand for?
Cystic fibrosis. And then, yeah, you just wait for the 10 minutes to be up, and then you try and cough. And a lot of times you can do this on top of other medications with nebulizers and then the high flow that's coming up as well. So a lot of times you do it along with everything else so you're not in the room forever.
Hey, Wyatt, can you have Brendan talk while you're vibrating him?
Oh, yeah.
All right, Brendan. Sing us a song, Brendan.
I can't. It's good.
All right, that's better.
All right, so they're going to get ready for the next station. So let's say initially the first station, they said if a patient requires some additional oxygen, we have other devices that can not only help give more oxygen, but it can also kind of help the patient catch their breath. So Brian here is going to explain this device here, and then he'll explain what the different uses of it are.
So this is called an airbow. If we have a patient who starts needing a higher flow, we call these a high flow device. It basically just means that it provides more air or oxygen than the patient would normally need. So this one is just like our regular nasal cannula. It just fits a little nicer and it's a little smoother. So Wyatt here, same idea. So this one fits a little bit tighter to the nose. Same idea. So with this one, we actually have it heated and humidified because when you supply such high levels of or volumes of air, it'll actually dry out their nose. And on this, you can change your concentration of oxygen by just turning on your little flow meters, and then it changes it automatically. And your screen usually it tells you your percentage, the flow rate of air that you have, and the temperature of your heater all in one. So these are for our patients who demand more oxygen, but not so much that they need a tube or a BiPAP.
Right. Just because I feel like I want to ask you, what is it that brought you guys to respiratory therapy?
I tried business and it was the most boring thing I've done in my life. So then I shadowed an RT because I knew I didn't want to be a nurse. And I shadowed RT and I loved it. I got to see an intubation and that's what pushed me over the edge.
What about you, Wyatt?
I had a pain in the butt anatomy teacher. Those of you at Dallas Down know who I'm talking about, Mr. Gould, who forced me to come to this. And then I chose this over physical therapy because it was less school.
All right. So now that we've
Hey, Shannon?
Yes.
Sorry to interrupt. So again, I just want to put this to what people may have heard in the field or out there. So for the high school students, they probably have heard people getting sicker with COVID. I don't mean to harp on COVID, but the therapy that Brendan just talked about is some of those therapies that have been talked about on the news. Okay, so high flow nasal cannula therapy has been talked about on the news as one of those things that we're doing that's new to help patients survive. So again, the reason I'm saying that is, guess what? Respiratory therapists are pretty cool because we are helping patients during a pandemic, and the therapy that Brendan and Wyatt just demonstrated to you is something that we've actually been doing for years. It's not brand new, but again, it's therapy that can be, in this case, life-saving. So I just want to put that out there.
All right. So with our patient, we've actually just given them a little oxygen. We've done some of their medications with them, tried to shake them up a little bit with the vest, loosen the secretions that they had. But, their oxygen didn't get that much better. So we had to put them on the high flow nasal cannula and give them a higher amount of oxygen. But they're still not that great. So the next step in the process, or what we would do next, is actually put them on non-invasive ventilation, or what you may have heard as a CPAP or a BiPAP. So I'll let these ladies explain to you what that is.
All right, this machine right here is a CPAP machine. CPAP stands for continuous positive airway pressure. So basically what it does is it pushes positive air down their throat and into their lungs so that they can breathe without having like a tube shoved down their throat, which would be invasive. Yeah, this is what it looks like.
This is also heated and humidified because we are putting dry air into their lungs, so we can overcome that a little bit by providing heat and moisture to their airways. What's this thing, Jules? Do you put this over your eye?
No, this is what we use to measure the size mask that goes over their face because we want to make sure that we have a really tight seal, or else we won't get all of the air that we're supposed to be getting. So these are the different sizes that we have.
And how do you measure it?
It has to kind of fit over their face like that.
Right.
If it's too big or if it's too small, then it won't cover all the area it needs to. And if it's too big, then you'll be able to tell if it's too big. But if it's too small, then it won't cover the proper area that it needs to.
All right. So after non-invasive, we try this first to, like Jill said, to avoid people from getting that breathing tube down their throat. But if this doesn't work, we have to move on to that. So Savannah will be showing you exactly how to intubate a patient and put that breathing tube down their airway. Go ahead, Savannah.
We do have two different kinds of blades. One's called a Miller, which is a straight blade, and one is called a Macintosh. Totally just personal preference, which one you want to use. This is the endo tube that we use to put down. What I have in here is called a stylet. This is just used to simply shape this so you can get a better angle for when you go in. I'm left-handed, so it's a little backwards. So I hold it like this. Put it up here. You have to push the tongue up so you can see back in there. Make sure you push it in and remove the stylet. There we go. And to make sure that we have it in, these lungs should expand. So I'm going to connect the ambu bag. And when I do that, the lungs are expanding. So we know that we have it in the right area. After we intubate, we fill up something called a cuff. We do have a cuff pressure manometer. We plug it in here and we inflate this to 30. That is because that's the pressure in here. So we inflate it to 30. We check this every 4 hours when we do the tube. And this is the tube securement. This is called a Hollister. We put this around here, put it around their head, and then secure the tube in there. Once they are intubated, we put them on something called a mechanical ventilator. And that is what Sarah is going to talk to you about.
We're going to go. You want to go first?
It's okay. Come over here. So Savannah is correct. After we put the breathing tube in, then we put the patient on a breathing machine. This is called a mechanical ventilator. And Sarah and Tara are going to explain a little bit of that to you.
Okay, so basically this is like a big bulk of what we do. We're in charge of managing the ventilators. So basically we set a whole bunch of different settings on here based upon the patient, their needs, and what they were intubated for can be a factor in it too. So if this were a patient, our test log, their oxygen is 50% oxygen. They have a tidal volume, which is the amount of air going into their lungs, of 520 milliliters. Ideal volume weight. Yeah, so there's a difference between the way you figure out their tidal volume is the difference between their weight and gender, right, and height. So there's a difference between ideal body weight, which is what we base everything off of, versus their actual body weight. Another factor is eye time, how long they take their breath in for, how many times a minute that they're going to be breathing. So this patient is set at 12 times a minute, and PEEP. That's set at 6. That is set to open up the patient's airways and lungs so that the alveoli can stay open and ventilation is easier for the patient. We monitor all these things based upon the readings on the side here. So it fluctuates. with almost every breath, but it should stay around the same values every time ideally. We can see more data on everything on this side. So you click here, there's a lot more to look at also, even more on that page. Yeah, there's alarms too. So if the alarms go off, so these are the alarms too. We're in charge of these. If these go off, that usually means that there's something going on within the circuit itself or with the patient. Are we doing UNET? Okay, and then after an hour of the patient being intubated and on the ventilator, we do an ABG check, which is an arterial blood gas, and Yasser will talk about that.
Okay, so we do check people to make sure the oxygenation in the blood is okay, the CO2 level, and the acid base balance. We do have.
What's unique about what we do compared to regular lab? What do we stick and why?
We stick in. We don't stick at venous. We stick at arterial because the level of the oxygenation is high. So we do have. This is our part. And we do Allen test to make sure. I'm gonna show you how we do the Allen test.
So while she's getting this set up, so when we do this, like Elzer said, we draw blood from arteries, not from veins, because you want to see how much oxygen goes to their body. So you have two arteries right here. You have a radial and an ulnar. So what Yasser is going to do is the Allen's test that she talked about. So you have the patient squeeze here, you relax, and you release this ulnar artery. Because if anything were to happen where you draw this blood, it tells you that you're going to still get blood to that hand, which is why we do this test. So we do this before every sample we take from that patient. And she's going to get this set up, and then she'll show you how we go about drawing those.
First, we fill the holes.
Now, would we usually have gloves on for a procedure like this?
Yeah, we use gloves.
we don't need it today, but yes, we would normally have a glove on for this.
Wipes by alcohol wipes. We try to do this to get the air out. Then we deliver to the lab. And finished.
So depending on what this tells us, this will give us information that'll tell us the adjustments we need to make on the ventilator and see if the patient's improving. If everything looks good, eventually our goal is to always get this tube out. Molly's going to show you what we do. So we talked about the OPEP device, the vest, stuff that we can do to help thin secretions. Molly's going to show you how to get them out. One thing we didn't show you, so let's say those labs came back, we were having trouble getting that initial this breathing tube out. Some patients, I'm sure you guys have all seen patients, they require these trach tubes. Essentially, if they require this for a longer period of time, these end up going in, they get placed lower than this, but essentially this is what this looks like. You've probably only seen the outsides, but this is what is used if a patient has a long time and requires additional support for a longer period of time on the ventilator. Molly here is going to show you what we do to get those secretions and that junk out of the patient's lungs if they have one of these breathing tubes in.
Okay, so obviously this patient would be connected to that mechanical ventilator. So what we do with this is called an inline suction catheter. This is connected in line with the patient's tube. So this is used for, like we said, mechanically ventilated patients. They are unable to clear the secretions for themselves. They may have weak coughs. So this kind of just helps get all that junk out of their lungs, help prevent from infection and different things like that. So what you would do, this would be connected to a suction canister, and you just slide it down the patient's tube. That goes down into the trachea, and then you'll push this down to start the suction, slowly pull it out, and that helps get all that gunk out of their lungs. We can also use one of these. This would be for patients like Mitch was talking about who would have a trach. As long as they're not mechanically ventilated, we could use this. And this is more of like a manual suction catheter. You would stick it down into their trach, kind of work around there, and it works in the same way. And this one can also go down into a patient's nose and down into their trachea, and again, suction in the same way to get all that gunk out of there. So at some point in the patient's stay, the patient's status could decline, which is where Nicole would come in, and her part of there would be the CPR aspect.
So if all else fails, we have an AED or a defibrillator. So we have these pads here, and these pads get placed on our patient's chest. One will go, it will reach. One will go over here on this side of the patient's chest. They kind of just stick on there. The other will go over here on this side of the patient's chest. From there, you turn your defibrillator on, and it will kind of walk you through what to do. If it does not turn on, ignore that. So the next thing you do is we rotate between compressions and breaths. So you'll kind of take your the palm of your hand here. Oh, sorry. And you'll put it right in between their sternum, kind of in between where the nipple line is. And from there, you'll press down and until you get good recoil, and you'll do this 30 times, kind of to the beat of Staying Alive, if anybody still knows what that song is. You can also do it to Baby Shark, so you do this about 30 times. And then after 30 breaths, you're gonna wanna tilt your patient's head back slightly, open their mouth, and then you start to bag them with this mask. So you want a good seal that covers their nose and their mouth. And then from there, you just slowly start giving breaths. So you just squeeze the bag and you give 2 breaths. And then you continue with your chest compressions once again until you get return of spontaneous circulation. All right. And so hopefully then they're alive.
So regardless if they're alive or if they do pass away, because obviously we have that happen, we end up taking the breathing tube out, and that's called extubation. So you saw Savannah put the breathing tube in. Now she's going to show you how to pull it out.
while they were doing the mech vent, I went ahead and put the Hollister on. Again, this just went around their head. These do come off and they're sticky on here. So one of the first things we do is, this is just Velcro over here. I'm just taking this out. And this would be sticking to their face. So we take a nice pad and try to kind of peel these away. Because that's been on their face for a couple of days. So that is really adhesive to their face. And we want to try to prevent any trauma to the face that we can. There's a couple different ways to extubate. I personally like the one where I can, I tell them to cough, and while they cough, I pull the tube out. So before we do this, we go down, we suction them, make sure we get anything out of the airway. We use a yank hour, get down there, make sure we get all the secretions out of the mouth. I hold the tube, I tell the patient to cough, and on the count of 3, they cough, and I just remove the tube while they're coughing. After you extubate someone, their voice is going to be very sore. They've had a breathing tube down their throat for a couple of days. So we try to work with them to make their muscles a little bit stronger, and they'll see other areas like speech pathology and stuff like that.
All right, Liv, we have a few more minutes, so I just wanted to ask a few questions. Now that you guys have seen everything that we do as respiratory therapists, actually I'm joking, that's not everything, but that's a big part of it. Just a few questions going out to our students. Tara, what do you like most about our program?
I think I like most about our program is like the clinical aspect. We get a lot of hands-on activity. We see patients, we have patients, we treat them. Our clinical instructors are with us and they walk us through things and they help us, but they let us do a lot of the stuff so we can get a lot of experience. So that's honestly my favorite part. We have great clinical instructors. They're very helpful, knowledgeable.
Yep. All right, now Tara told us what she likes best about the program, but Sarah, what do you like best about being a respiratory therapist?
Being able to be on like the front lines and knowing how to treat these patients, especially nowadays, like it's very beneficial, and I think like rewarding as a whole, knowing that like you can help all these people and they could be literally dying and you can bring them back to life. Like that's an awesome kind of feeling. But I mean, that's what I like about being a respiratory therapist. You're very hands-on here.
And then finally, Savannah, what is the worst part about being a respiratory therapist?
I do like everything. With our job comes a lot of sputum. It sometimes can get a little gross.
What exactly is sputum?
All the junk you cough up when you're sick and all that gunk in your lungs and stuff, that all comes up, and we deal with all that kind of stuff. And sometimes, you get it on you and it's not the prettiest thing, but it's part of our job and we do it.
All right. I think that's it. Back over to you, Tony.
There we go. Thank you, everyone. All right. Well, if I wish I could have a virtual round of applause. So if you're there and you can at least applaud our students and our instructors in the room, that would be great. Actually, I don't need my mask on. I'm here by myself. I get so accustomed to having a mask on. So there was a few questions and some about volunteering, things like that. However, there was a good question about from an anonymous attendee. Is there any risk with using the breathing tube? There seems to be a lot of other equipment for an easier way to help a patient breathe. That is an excellent question and good thought process. The breathing tubes are obviously very dangerous. We don't put just tubes on anybody. They obviously have to have they have to be in very bad shape to get a breathing tube. So some of the things that I believe Jules and Jenna had showed you with that mask on their face, and it was called BiPAP or PEEP, or so that's something we do all the time, or something that Wyatt and Brendan showed you with the nasal cannula, the prongs in their nose. So those things can help people breathe. So especially that mask that's pushing air into someone's lungs or assisting their diaphragm. And everybody knows, if you're in here, the diaphragm is our main major muscle to breathe. So if we can use some of those devices to offload or let the diaphragm rest, we are going to have much more success. So yes, the endotracheal tube, put that breathing tube in, is the last thing we want to do for most patients. Some patients, once you do that, they do very poorly. Obviously, think about having a large tube in your mouth, or a large straw. Or for Tara, I'm going to talk to Tara right now, having about 4 or 5 straws in your throat. Can you imagine? That's very comfortable. So yeah, so these patients need pain medication. They need sedation. So once you start doing that to someone, the risk increases. So that was a very good question. And again, we do try to use a lot of technology, a lot of new technology that keeps coming out. One thing about this field is we've been around for 60, 70 years, even though a lot of people haven't heard about us. There is a lot of new equipment. In fact, a vendor stopped in just this morning with new equipment, because there's new equipment all the time to make care better. So I'm going to share my screen now. Again, please ask questions, throw some more down the Q&A. I would love to have more questions. The other questions surround volunteering, and you guys are all of the perfect age, most likely. If you're participating with YCal, you're most likely all of age to volunteer. Unfortunately, at this time, because of the pandemic, I don't think the hospital, especially now, actually the hospital has eliminated all visiting as of yesterday because of the pandemic in York County. So that would be certainly something that, depending where you are in high school, that would be great to come in and volunteer. It looks great on a resume for college, looks great on a resume for a job. Plus you get experience. And sometimes, I'm gonna use my son as an example. He volunteered years ago, and he came back in the hospital and got a job in the hospital because people knew him from volunteering. Just seeing if there's any more questions. So there's another question about, to relate to my question beforehand about the breathing tube. What makes someone unable to use a breathing tube? Not too many times can we, I think the question is, so it says, what makes someone unable to use a breathing tube? Again, I think we can use that with anyone. Some people are tougher to put in. So what you saw Savannah do on that mannequin, it was fairly simple to put in. However, there are some people that it's harder to put them in. And so those people that may have significant weight, maybe they have a really short neck, or their mouth can't open as big. So those patients, it's harder to get in, and that's called a difficult intubation. So those patients might be more difficult to get in, but we can get a tube into anybody if we have time. If we have time, we can take them to the operating room. Mitch and Molly showed you a trach tube, so I'm pointing down my neck. That person could get a trach tube in an emergency. So we can get anybody on breathing tube. And I hope that answers your question. If not, Adriana, if that does not answer your question, please let me know. Please get back on the Q&A and let me know that did not answer your question entirely. All right. As of now, there are no more Q&A. Kevin, do we have anything right now before I share my screen?
Yeah, sorry, I actually had two questions. I didn't know if you were going to talk about some of the requirements of the program, but typically a lot of I didn't see any questions come in about this, but a lot of times we get questions like, what can I do in high school? What are some classes I might be able to take if I have a chance to have any electives in my course load? What can I take now to help prepare me for what I would need to do in terms of studying and training to enter into this field?
That's a great question, Kevin. Thank you. It's like you've done this before. You know me or something.
A couple times.
All right. So in the meantime, in high school, what respiratory therapy, in order to be competitive, when you get into a school, you need to have some decent science and math. So science is like obviously anatomy and physiology, even chemistry, believe it or not, even chemistry, some physics. If you can take some advanced math courses, be good in algebra. We actually require that you take some calculus in courses like this. So if you have some strong math skills, or if you don't have strong math skills, recognizing that and working on it now. My students love math. I mean, they tell me every single day that they want more math, and they're probably laughing at me right now if they're paying attention. But anyway, so there's a lot of math. Physiology is math, so we love to talk about the math to understand concepts. So again, I would concentrate on a lot on sciences in high school and some math. And again, if that doesn't, you're not strong in those, that's where you need to boost up. And that's probably true of any healthcare career, to be honest. Sciences and math. You know, I'm trying to think of it. Yeah, so there's statistics. Yeah, so those are the major requirements. So for your college to get into any healthcare program, you need at least around a 1050 on your SAT. Now they may stress that less, but I don't want to discourage people if you get a 1030 or even a 1000 or 930, whatever. I don't want to discourage you from applying to a good school. It doesn't always mean that. So I'll look at anybody, to be honest, but we do have some admission criteria. So again, concentrate on those math and sciences while you have a chance. Kevin, if you want to go ahead and answer that question.
Yes, I can answer that. Someone had asked, does Wellspan host any other events explaining other medical jobs? I actually didn't say this at the start of the program. We have through 2020 planned out. I believe this was the last of the healthcare programs for 2020. However, we just made the decision because of various reasons. We'll be doing all virtual programs again in the spring. So I don't have any exactly on the schedule yet, but I know we typically would have a rather large nursing program with Wellspan in the spring, normally around April. I'm certainly going to work to see if they would be willing and able to do that virtually. So the best answer I can give you is stay tuned, and I very much hope so that we will be able to partner with Wellspan to promote some other medical jobs and careers as you make your decision. So stay tuned. I'm not sure what school you're from because it says anonymous attendee, but just keep in touch with the counselor that got you set up with this program today, and they will be one of the first ones to know when we have those available.
Thank you, Kevin. Perfect answer as always. Yeah. So please pay attention. Obviously, Kevin, as Kevin just said, we're going virtual all next springs. But if you are of the age where you could maybe come back in the fall, certainly consider that. And hopefully in the fall, we can. So there's some of those things you saw in the classroom, or any healthcare career that you might be able to sign up for. Maybe you'll get some more hands-on in the fall. Unfortunately, this pandemic. I'm sorry, guys. I wish better for you. Especially as you make your decision about what you're going to do in the rest of your life. But we have to hang in there, and hopefully things like this can help you. So I'm going to share my screen right now. I'm going to show a short video. Actually, I'm going to show there we go. So hopefully everyone sees a screen that says BNRT. Everyone see that? Kevin, can you confirm that that's what we're seeing right now?
Yes.
Okay, thank you. Okay, so if you ever want to, so write down this website, b-rt.org, or just search for bnrt.org. All right, and so a lot of the questions that maybe I don't answer today. So here I'm showing you right now that it says high school students, find your path. And so some of the questions that maybe, we're trying to answer today, here it says high school student, your resources. And so you're taking a first great step right now. Staying in contact with your guidance counselor, doing things with YCal. You have a great resource here in your county. If we could ever go back to career fairs, that'd be excellent. But again, we'll work through that. And here we have currently an associate degree is required. However, many healthcare professions are growing. So consider that your education, you're going to go for at least a 4-year degree. And so volunteering with your state society is great, but again, so many of these things are limited right now. And as some of the Q&A went through, volunteering at your local hospital is a great way to help out too. It doesn't have to be Wellspan, but obviously I'm going to encourage you to volunteer at Wellspan when you can. Here's that thing about credentials in the purple, and then again, follow that BNRT. So we're going to go back to the find your path. Actually, I'm going to fill it back. So I'm going to show about a 4-minute video. You can see here on your screen that there are 6 videos on this webpage. And probably in total, there's no more. These videos do not add up to 15 minutes. So it's fairly short time to actually watch videos. I'm sure everyone here likes YouTube, but I'm going to show you, I believe it's this video here. I believe it's about 4 minutes long. But we're going to show it to you. And again, please keep bringing the questions into us. So we're going to sit back for about 4 minutes and 54 seconds. Enjoy.
I'm a respiratory therapist.
I am a respiratory therapist.
I'm a respiratory therapist, and I save lives. A respiratory therapist is a professional who has been trained to work with patients who are affected with chronic lung disease across the spectrum. So anything that affects your breathing, a respiratory therapist is likely going to be involved in the care of that patient. A respiratory therapist is not only a therapist, but a practitioner. We help patients in so many different capacities, not only with breathing, but with education, with lifestyle. So we have many different roles throughout healthcare. It can involve working in a hospital such as the ICU, in neonatal ICU. We can work in the emergency department. We can work in diagnostics and therapeutics. We do outpatient education. We do smoking cessation, asthma education. We work in pediatrics. So, you know, a respiratory therapist, we hold so many different roles that really help the community in so many different ways.
I'm a respiratory therapist.
I'm a respiratory therapist, and I care for my patients breath by breath.
The thing I like most about it is the variety of the day and the variety of the career. In the hospital I'm at, we have neonates all the way up to adults. We have a burn ICU, trauma ICU, so we can be anywhere at any time of the day.
There is always a patient that needs something unique. Sometimes there are physicians that have different needs that we have to take care of.
Obviously, it starts off finding out where I'm at, where I'm assigned to, getting a report from the night shift, seeing what the plan is for the patients, and then going to see every patient, doing rounds.
I work in pediatrics, so I may get 5 patients, may get 6 patients, but they're patients that need help with breathing. And my job is to provide them with their treatments. A typical day would be going from giving a treatment to maybe a 5 or 6-year-old that's slightly sick, then going into an intensive care unit, somebody that's much more ill, and every decision that I make on how to set that life support machine could affect their outcome.
We have so many different pieces of equipment, and they all do so many different things, from a wide variety of life support equipment to sustaining equipment to equipment that just will deliver oxygen.
So a typical day is checking equipment, getting with our people. We also will go in-house and check on the therapists in-house and see if they need anything. But primarily, we're waiting for calls, and they come. We usually do 2 to 4 transports a night. They can be anywhere from 2 or 3 hours long to 6 hours long, or sometimes even beyond the shift. We see each patient anywhere from 1 time a day to 6 times a day, depending on the type of patient.
Day will typically end right about 5, 6 o'clock in the evening, so about 12-hour days. I'm a respiratory therapist.
I'm a respiratory therapist, and I love taking care of people.
I worked in a teaching hospital, so it was routine that we always had students, following us. Precepting students was one of our responsibilities. So that's how I got into education. I became a clinical instructor. That also opened another door for me when a program director position became available. Empowering the patient to manage their chronic lung disease so that they understand that they can live a good life. It's about quality of life. So I feel that if I can help teach them on how to handle their chronic lung disease, it's about having the confidence that they're going to be okay.
The education and dealing with the patients, it's very satisfying to me. You go in a room with someone you haven't seen in a while, but they look at you, the family looks at you, and they remember you, and they're happy to see you. And that makes my day. It makes it all worth it. So I'm a respiratory therapist.
I'm a respiratory therapist. I'm a respiratory therapist, and I make a difference.
Okay. Hopefully that was a invigorating little website for you. So I had a question while this was playing about websites that may for all careers. To be honest, this is a brand new website for us, and so I'm pretty proud of this website that we actually have something that's better than what we used to have. So it is a great website. However, if you're interested in something else, as I entertained in the question and answer, sometimes if you're just interested in local colleges, go to their website and maybe you can see something, and they may have links. So that your college, for an example, when you go to respiratory therapy, we have a link on there for exactly this BNRT, I believe. But if you're interested in other fields, they may have a link on there that you can learn more about that field. And certainly you can contact. If you contact me about respiratory therapy, I am not going to tell you you have to come to your college. I will tell you I love the field, so I will tell you go wherever you want to go. That sounds sort of rude. But anyway, no, I'm not here to talk to you just about coming to your college. I am here to talk about respiratory therapy. So again, I will be a resource to you. My email, if you ever want to contact, my email is simply trupert@wellspan.org. Again, trupert@wellspan.org. Just contact me and we can go from there. One of my panelists did remind me that for an example, here at your college, the way this program is set up, you essentially have 2 years of general education or science, math and sciences at the college. And then the bulk of your next 2 years, the bulk of you, so you saw our juniors and seniors, the bulk of their time is spent here at York Hospital, York Hospital, to do clinicals, to do class work, and to learn equipment. So they do have some classes at the college, but depending on where you go, if you go for a bachelor degree, you may spend 2 or 3 years at the college and then go all clinical for the rest of the time. So by the time you leave our program, you get closer to 800 hours of clinical time, clinical exposure. So, all right, well, Kevin, we're at least in the 11 o'clock hour. Anything else that you have here? Oh, thank you, Kevin. Kevin is good about posting things.
I'm busy. Yeah, I did just want to say I did put that BNRT URL in the chat. So if you type or if you press in the chat there, you can access it right there, just in case you weren't able to type it down fast enough. And then also, if anyone, I'm just reading what I just wrote there. If you have to be at a point in your career where you're looking at what's your next step after high school, there is a link there. I do believe if you click on that, Tony's email is on that page somewhere as well. So if you didn't write that down, oh, there you go. Look at that. And Tony's on top of things too. Look at this. What a great team. We practiced so much for this today. So that information's there. And, if you ever need anything else, and, info@ycal.us is another one. We can help direct you to the right place. I don't know if there's anything else on Tony's side, but I don't want to miss the opportunity to once again say thank you for doing this. Again, you have such a great program, and it's great to have everyone at the stations and actually get their hands on the equipment and do some of the work that we watched your students do. But certainly safety first. We can't do that this year, but hopefully in 2021. Fast forward to the fall of 2021, we'll be back in there and being able to do this, and it'll be great once again. So thank you for doing this, and thank you to all the students. I don't know if they're still listening, but really appreciate it. And it was good to see. I think I saw 1 or 2 familiar faces that may have been high school students working with this equipment a couple of years ago. So that is really awesome to see. I definitely recognized a few people, so that's great.
Great, thank you, Kevin. I think this worked out well despite the restrictions that we have, and I hope that all participants enjoyed it. Certainly, if you enjoyed it, or you think that someone would enjoy respiratory therapy, certainly reach out to them. And going back again to that Q&A, I think YCal is a great place to start. And Kevin's a great example of if you're interested in anything else, it's not just about respiratory, it's not just about nursing, but Kevin has great resources that you can reach out to YCal for. And so there we are. We're complimenting each other, Kevin.
All right. Well, hey, thank you so much again. This has been the Respiratory Care Virtual Career Exploration Program for 2020. And just want to say thank you, everyone, and stay safe, and we'll see you soon. Thanks.